give you an antidote, or are we just going to reduce dose? What are we going to do? So we use this a lot in practice to figure out what to do when people are falling outside the norm, the range that we have designated as therapeutic. Prosthetic heart valves, you can see it depending on whether it's in the mitral or the aortic position. Mitral valves, mechanical, are going to be your highest risk for embolism. Atrial fib, low ejection fraction, hypercoagulable states, atherosclerotic disease, STEMIs, left atrial enlargement. These are the people who are at risk for embolizing. These are the people we're going to anticoagulate. You'll see that a bioprosthetic valve that's in the aortic position, lower risk. Doesn't mean we don't anticoagulate them for at least a period of time. Okay. Did you all talk about valves and valve replacement?
Not yet. I get to that
Today? Okay. So as you're listening today, listen to which valves have been replaced. So we're just going to be mitral or aortic, and what type did they use. So you can see the mechanical valves. That's this one. You can see it when it's closed. Here's what it looks like in place. And here's a porcine valve, tissue valve. Okay. Venous thrombosis. Mostly fibrin and red blood cells, not a lot of platelet. Can occur anywhere. Embolization we talked about being to the lung. Signs of a DVT. So what are the signs? Swelling usually. So it's usually hot, usually have inflammation. What about, what can you do? Claudication in terms of what? Hurts when they walk, okay? What can you do to them? Did you talk about Holman sign?
Yes.
Okay, so what does that tell you? It's a great test, but one you can use. Signs and symptoms of a PE listed there: dyspnea, tachypnea, tachycardia, pleuritic chest pain. Usually it's shortness of breath is prominent. PE complications, death, about 25% is the mortality rate. Pulmonary hypertension, because they get clots in a lot of the lung field, then their ability to ventilate and perfuse is off, and so it takes some time over a period of a few years for them to resolve those clots and to get function back. They may never get back to normal, but that puts increased pressure back on the right ventricle. So they can have right-sided heart failure due to that increased pressure within the pulmonary system, which would be cor pulmonale. And then recurrent VTEs are another complication of that. Complications of DVTs are the PE prosthrombotic syndrome. You can get venous insufficiency, damage to those valves. So they have poor circulation in the lower extremity. And I've got a picture of chronic venous insufficiency, but it's at the end of the slide set. Common etiologies for venous thromboembolism. So vascular surgery, or vascular injury, sorry. Trauma, indwelling catheters, stasis, immobilization, obesity, varicose veins, having somebody who's on estrogen replacement therapy, birth control pills, and immobilized, that's a bad combination. Putting people in casts that immobilize also are a problem that will keep them from, or lead to stasis. Hypercoagulable states. Malignancy is a very common one. We commonly now will sometimes with cancers, we will go ahead and anticoagulate them. We also know that embolic events often will run a year or two ahead of somebody being diagnosed with cancer. Inflammatory bowel disease, hormone therapy, that can be birth control pills. Estrogen component is the main problem. Or for postmenopausal women on estrogen replacement. Pregnancy, we talked about. The last 5 are some type of change within the clotting cascade. So these would be common ones we would work, like if you all came in, we would work you up for these because it would not be normal for you to have these. So we look for antiphospholipid, we look for factor 5 Leiden or Leiden deficiency. I don't know much about the prothrombin 2021 gene mutation. I haven't seen that one show up in co-ed clinic. But protein C, very common. Protein S, common also, and then antithrombin deficiency. So lots of reasons for people to produce clots. Drug therapy. So these are things I want you to keep in mind. These would be big things to look at as you're considering therapy and how they differ. One is the route of administration. So most of what we do acutely is parenteral, either IV or subcutaneous. We can use some of the newer oral agents in acute situations. Most chronic are going to be PO, but not all of them. In pregnancy, we use heparin, so they inject themselves. Often with cancers, the oncologists tend to like to use the heparins instead of the oral agents. The other is reversibility of a reversal agent. Not all of these agents have something that will reverse if they have a major bleed, or you have to take an injury procedure or surgery, and you want to reverse the effects quickly. That is one thing to keep in mind. I'll point that out as we go through. Time to full therapeutic effect. Heparin, right away. Warfarin, 7 days. So how fast? Because that will dictate as to whether we need to overlap a quick acting or immediate acting with a longer acting. So when we start heparin, when we start warfarin, we always start a heparin with it for 5 to 7 days to cover that time when warfarin is still exerting its effect. The ability to monitor. So a lot of the agents you've learned about prothrombin time, you've learned about APTT. So we can use that to adjust a therapy into a target. Here it's not a therapeutic range, it is a target that's looking at how long it takes the blood to clot versus someone who is not on an anticoagulant, how long it takes their blood to clot. So it's a little bit different approach. The newer agents don't have that, so we don't know if they are, if it's being effective or not. And then the last is renal impairment. Some of the drugs can be used in those people who have renal impairment, and some cannot. So those are the big issues with the different agents. Okay, before we start heparin, let's take a break. We'll come back in about 7 minutes, about 7 till.